Good morning. My name is Jordan Sexton, and I will be your moderator for the workshop. Welcome to the workshop, Graft-versus-host-disease, What to Know, What to Do. Before we begin, I'd like to thank Incyte Corporation and Sanofi, whose support helped make this workshop possible. It is now my pleasure to introduce our speaker, Dr. Farhad Khimani. Dr. Khimani is an associate professor in the Blood and Transplant and Cellular Immunotherapy Department of Moffitt Cancer Center in Tampa, Florida. His clinical work focuses on treating patients with Hodgkin lymphoma, non-Hodgkin lymphoma, acute myeloid leukemia, acute lymphoblastic leukemia, myelodysplastic syndrome, and myeloproliferative neoplasms. His research and clinical trial activity focus primarily on graft-versus-host-disease, GVHD. Please join me in welcoming Dr. Khimani.
Thank you for the kind introduction and invitation to an opportunity to speak on this platform. So let's get started here. This is just the center, Moffitt Cancer Center in Tampa, Florida, where I currently work as a transplant physician. A few learning objectives. I would try to keep it simple and straightforward. Briefly, just going to talk about what is this graft versus host disease that we talk about whenever we are talking about stem cell transplant. And then, are there any types of graft versus host disease? And if there are, what are those types, and how do we classify them? And then we'll briefly talk about why it happens in patients, and then how does it affect patients who do develop graft versus host disease. And then we'll briefly go over, is there any way to prevent graft versus host disease, and and if it occurs, do we know how to treat it? Now, what is graft versus host disease? It is one of the major complications patients who receive donor stem cell transplant, what we also call allogenic stem cell transplant. You may hear these terms: bone marrow transplant, peripheral blood stem cell transplant, allogenic stem cell transplant, donor stem cell transplant. All these terminologies are more or less mean the same thing. There are two different types of transplants that we do essentially. One is from patient's own cells, called autologous transplant, and the other one is from cells from a donor, called donor stem cell or allogenic transplant. But we use a variety of different terms: BMT, bone marrow transplant, stem cell transplant, things like that. Now, in allogenic transplant or donor stem cell transplant, the reason we do this transplant, the way it works is we want the donor cells to go into the patient's body and start fighting the cancer, the malignancy. Most commonly, we do these kinds of transplants for patients with acute leukemias or lymphoma or myelodysplastic syndrome, things like that. So we want the donor cells to go into a patient's or a recipient's body and make a new immune system and start fighting with the cancer or malignancy to beat the malignancy, essentially. But these same donor cells, as a bystander damage, may also start fighting with the patient's or recipient's body organs. And that essentially is what graft versus host disease. Graft meaning donor cells, host meaning patient's body organs. We want the donor cells to fight the cancer, but at the same time, it has the potential to also fight the patient's body organs, which is called graft versus host disease. It is essentially an immune disease and has a lot of similarities with other autoimmune conditions. If you may have heard of diseases like lupus or rheumatoid arthritis. So graft versus host disease manifestations or symptoms can be very much similar to some of these autoimmune diseases. So what do we want from an allogenic transplant from the donor cells? We want the donor cells to be active enough to fight off the malignancy. But what we don't want is, we don't want the donor cells essentially, especially in a severe form, to fight off donor recipients or patients' body organs. So this is just a simple diagram, and I'm going to go through it to kind of explain what happens. So whenever we are doing a donor transplant, we are first collecting donor stem cells. Either we collect directly from the bone marrow, these are the hip bones where most of the bone marrow formation occurs, apart from some of the other bony areas, or mostly these days we collect these stem cells from the blood. There's a process called stem cell mobilization and apheresis, where these stem cells, we push them with a medication to come out in the circulating blood, and then we collect it through peripheral blood. But once we have these stem cells collected from a donor, we infuse it into the patient or the recipient. When these cells go into the patient, they form a new bone marrow and a new immune system, which is what we want. But at the same time, the immune cells from the marrow, the white cells, can also go and start fighting off the patient's organs like liver, bowel, skin. And that's what graft-versus-host disease is, and that's how it essentially works in the patient's body. Now, we all have immune systems, and our body is able to fight off essentially any foreign object or material that comes into our body. For example, let's just say we get an infection from a bacteria or a virus. When a bacteria or virus somehow gets in our body, our immune system or our white cells recognize them as foreign material and start fighting it off. And that's the normal process of immune system. Now, in this case, when we are doing a transplant from a donor, to prepare the body to be able to take the donor cells, everybody gets some form of chemotherapy or radiation. What that chemotherapy or radiation is supposed to do is supposed to suppress the patient's immune system so that the donor cells can take. But at the same time, the same chemotherapy and radiation is also causing some damage to the patient's body organs. For example, let's just say one example would be our gut, our intestines. When that damage happens, the bacteria, the cells from the intestines get broken down and damaged, and releases a lot of proteins and foreign material inside the blood that circulates. Now that triggers a response from the donor cells, what we have infused when we injected the patient with the stem cell transplant cells from the donor. Now these donor white cells, what they do is they are hovering around. When these special proteins go into the blood, there are special cells in the blood that recognize that protein and present it to the donor immune cells. And when these donor immune cells recognize these proteins as foreign, then they start going back to the organ and start attacking the body organs of the patient. And that's how graft-versus-host disease manifests. Now, what are the types of graft-versus-host disease? Essentially, there are two major types of graft-versus-host disease. One, what we call acute graft-versus-host disease, and the second, what we call chronic graft-versus-host disease. If GVHD or graft-versus-host disease happens early on after stem cell transplant in the first 100 days, essentially what acute graft-versus-host disease is. If it happens after the first 100 days, it's chronic graft-versus-host disease. But there is a small caveat in that. Some symptoms of acute and chronic graft-versus-host disease are very peculiar to either acute or chronic graft-versus-host disease. which may or may not follow this time-based division. For example, dry eyes and dry mouth is very peculiar of chronic graft-versus-host disease and not acute. So in some rare situations, if dry eyes or dry mouth based symptomatology or graft-versus-host disease symptoms develop at day 90, for example, or day 80, for example, that would still be a form of chronic graft-versus-host disease that happened early on. That happens in some patients, and that's why there are some other terms that we use. So based on the symptomatology, there are two other terms. One is called overlap graft-versus-host disease, meaning if somebody developed chronic graft-versus-host disease along with acute graft-versus-host disease symptomatology that may or may not follow this exact timeline of 100 days, then we may call it overlap graft-versus-host disease. Similarly, if acute graft-versus-host disease symptomatology occurs without chronic graft-versus-host disease symptoms after 100 days post-transplant, we call it late acute graft-versus-host disease. Now, what are the symptoms of acute graft-versus-host disease? It essentially affects three organs. The classical acute, most common acute graft-versus-host disease affects three body organs: the intestines, the guts, the skin, and the liver. In the skin, it causes rashes, mostly red rashes, which can be very itchy in some patients, nausea, vomiting, diarrhea, and appetite loss if it affects the gut, and abnormality of liver enzymes, AST, ALT, and bilirubin if it affects the liver. Chronic graft-versus-host disease, on the other hand, can virtually affect any organ. It may include the organs affected in acute graft-versus-host disease, such as skin, liver, and the gut, but it can also affect other organs like mouth, eyes, lungs, joints, etc. On this slide, you can see the incidence of involvement of variety of different organs by chronic graft-versus-host disease. Skin involvement is very common, mouth involvement, liver involvement, eye involvement, and then, in some patients, they may only have weight loss. We use a term called GVHD anorexia, when they may not have a lot of other symptomatology, but they are losing weight. So that's why it's very essential. If you have any symptoms, if you have received an allogeneic transplant, and if you have any symptomatology which is not normal, you should let your transplant team know as soon as possible that you have developed a symptom, no matter how much trivial those symptoms are. Lungs, esophagus, joints can certainly be involved with chronic graft-versus-host disease. And as I said, late acute graft-versus-host disease, and when you develop acute graft-versus-host disease symptomatology like diarrhea, nausea, vomiting, and or skin rashes or liver abnormalities, but if they happen after day 100 post-transplant, we call it late acute graft-versus-host disease. Whereas overlap graft-versus-host disease is the term used when you have symptoms for both acute and chronic graft-versus-host disease. This is just a simple chart diagram to describe the same classification of acute graft-versus-host disease versus chronic graft-versus-host disease versus overlap and late acute. So classic graft-versus-host disease, if the symptoms of nausea, vomiting, diarrhea, rashes, or liver problems happen within 100 days after a stem cell transplant. Day 0 is the day when patients receive the stem cell transplant or the stem cell transplant infusion. And then you start counting the days 1, 2, 3, 4 after that. So first 100 days after transplant, if you have these symptoms, it's called classical acute graft-versus-host disease. If the same symptoms of nausea, vomiting, diarrhea, skin rashes happen after day 100 without any symptoms of chronic graft-versus-host disease, we use the term late acute graft-versus-host disease. If the patients have graft-versus-host disease symptoms occurring after day 100, and most of these are chronic symptoms like dry mouth, dry eyes, skin changes, nail changes, all the classic chronic graft-versus-host disease symptoms is called classic chronic. But if the patient also has acute graft-versus-host disease symptoms like red rashes or diarrhea, nausea, vomiting, which is attributable to acute graft-versus-host disease symptomatology, we call it overlap graft-versus-host disease, meaning the patient has both acute and chronic GVHD symptoms. Now again, why graft-versus-host disease happen? As I said, the donor cells are supposed to fight off the cancer, but they can also start fighting off the patient's body organs. And that's essentially the reason why graft-versus-host disease happens. And as I said, the chemotherapy, radiation, infections that happen around the type of transplantation that damages the surface of the gut or skin and bacteria and other foreign objects goes into the patient's blood and releases different kinds of proteins that immune system, in this case donor's immune system, do not recognize as self, and that triggers a subsequent process, a chain reaction where variety of different white cells from the donor starts releasing all kinds of chemicals that causes damage to the patient and causes inflammation and fibrosis vis-a-vis graft-versus-host disease. So as I mentioned, that chronic graft-versus-host disease can affect virtually every organ. And acute graft-versus-host disease essentially for most all patients affects skin, liver, and intestines. But it has been described in the literature that even acute graft-versus-host disease early on can affect some other organs. It's very rare. We don't see it very often, very, very rare. But it has been described that in some patients, it can affect the brain, the lymph nodes, lungs, thymus, kidneys, ovaries, testes, and bone marrow. Now, how often do we see this graft-versus-host disease, acute and chronic? First of all, it does not happen in everybody. And if it happens, not all of the graft-versus-host disease is bad or severe. There are grades, 1, 2, 3, 4, mild, moderate, or severe. With current standard regimens that we use for transplantation, the bad graft-versus-host disease or the higher grade graft-versus-host disease, such as grade 3 to 4 acute graft-versus-host disease or moderate to severe chronic graft-versus-host disease, happens in about, give or take, 5 to 10% of the patients, which is very good in terms of what we used to get back in the days. More recently, in the past 5 to 10 years, newer and more effective regimens have been designed that really have improved the incidence, reduced the incidence of acute and chronic graft-versus-host disease. Now, what are the risk factors for graft-versus-host disease? Are there any patients out there or any situations out there which puts a given patient at a higher risk of graft-versus-host disease? Yes, there are certain risk factors that have been described that lead to a higher risk of graft-versus-host disease. As I mentioned earlier, every patient who gets a transplant, we give them some form of chemotherapy or radiation right before transplant, so to prepare their body to be able to take the donor cells. If we do not give them that chemotherapy or radiation, patient's body is going to reject the donor cells right away and we cannot do the transplant. Now, there are different types of regimens, chemotherapy, radiation regimens that we use to prepare the body for transplant. If we use a very intensive or very high dose chemotherapy regimen as opposed to a lower intensity chemotherapy regimen, the risk is higher for graft-versus-host disease. Another important factor is the type of donor we use. If we use a fully matched sibling donor that has a lower risk of graft-versus-host disease as opposed to if we use an unrelated donor or a mismatched donor or a haploidentical donor. also, if the patient or the donor, the older they are, they're also increasing the risk of graft-versus-host disease. If the patient were to develop any infections along this time, that puts the patient at a high risk of graft-versus-host disease. Also, the type of graft we use, if we infuse a peripheral blood collected stem cells from the donor as opposed to directly collecting a marrow graft, also increases the risk of graft-versus-host disease. But there are different reasons why one or the other of these regimens or grafts are used for a variety of different reasons. Now, this is just a picture that is showing patients with skin rashes affected by graft-versus-host disease. They may have some red rashes, they may have some skin thickening, or variety of different form of manifestation or symptoms of skin in the graft-versus-host disease context. This is a little bit of a busy slide. I'm just gonna try to explain it to make it more simple. The idea to present this slide is to highlight that there are many organs that can be affected by chronic graft-versus-host disease. Some of the organs is what we call typical organs or common organs affected, meaning these types of graft-versus-host disease symptomatology we see very commonly. Dry eyes when it affects the eyes, dry mouth, white lesions inside the mouth or ulcerations in the mouth, shortness of breath or symptoms in the lungs, swallowing problem, dysphagia can happen in chronic graft-versus-host disease, affecting the female or male organs, causing vaginal scarring or problems with phimosis or stenosis in males' organs. All kinds of rashes, hyperpigmentation, different kinds of skin discoloration, skin thickening, leathery skin, things like that. Joint stiffness, joint pain when it involves the joints. These are the classical symptoms of chronic graft-versus-host disease, and whenever we see these things in our practices, all of our team members, it's easy to recognize because these are common symptoms. But then there are what we call atypical organ involvement, which we don't see very commonly. It can affect the brain, may cause memory issues in some patients, inflammation of meninges or the layer that covers our brains, vasculitis, meaning the blood vessels that are part of our brain and nervous system can be inflamed, causing issues and problems. It can cause neuropathy, numbness, and tingling of a variety of different areas in the body, muscle weakness like myasthenia gravis type of symptoms, non-classical involvement of the lungs, restrictive lung disease in some patients. Serositis is a very interesting manifestation of chronic graft-versus-host disease. When it affects the layer that covers our heart, our lungs, and our intestine, causing all kinds of fluid around our heart, around our lungs, around in our stomach, and we call them effusions or ascites. It can affect the kidneys, muscle cramps. There are a small percentage of patients who presents with muscle cramp that can be very severe in some patients. Joint pains can affect and can cause your blood counts to go down. Those are some atypical manifestations of chronic graft-versus-host disease. So essentially the message I'm trying to get through is chronic graft-versus-host disease can essentially affect any organs. That's why we tell our patients that, no matter what type of symptoms you have, how trivial or severe or non-severe they are, if you're noticing something, anything at all that is not normal, share it with your healthcare team, with your transplant team right away, and then they can guide you if any of those symptoms are of concern, number one, and how to help you to solve that problem, to improve your symptoms, and investigate if any of those symptoms are are related to graft-versus-host disease or not. So that's the most important aspect of managing graft versus host disease is to be alert and speak with your transplant team whether you have any symptoms at all. If you notice a little small amount of rash anywhere, or nausea, or you notice something in your urine, things like that, muscle aches, joint pain, anything at all. Another pictorial pictures of a patient with graft versus host disease. So graft versus host disease, when it involves skin, some patients may still persist, even when the graft versus host disease goes into remission, may still persist to have some changes, or what we call sometimes scarring or residual changes in the skin. For example, this is red active erythema or erythematous rash or active graft versus host disease manifestation. On the other hand, there's some hyperpigmentation, which is also manifestation of graft versus host disease. It can also just be a residual changes from treated graft versus host disease. So it's essential for your healthcare provider to review and examine you at short interval of time to assess whether whatever you notice on your skin, is it active or not in terms of graft versus host disease, and that will help guide them whether the patient needs treatment or not at any given time during the course of their disease. Essentially showing variety of different skin graft versus host disease. Here you see the joint graft versus host disease, where patient is not able to extend their hand joints properly, some sclerosis or leathery skin on the stomach, scarring in the forearm of the skin, and so on and so forth. So GVHD on the skin can present in a variety of different forms. It's not a straightforward one type of skin change. It could be any variety of different types, and it's essential that anything you notice you share with your doctor. These are some of the common examples of graft versus host disease of the mouth. You may see this white, what we call lichenoid changes, some on the tongue, the roof of the mouth. In some patients, they can be painful or symptomatic. It may affect your taste buds. It may cause problems with tolerating spicy foods or hot or cold food. In some patients, it can also be asymptomatic. So the key is to keep an eye on these things. If you notice something, even if you don't have any symptoms, speak up and let your team know so that they can keep an eye and follow up on these symptoms to make sure they don't require any other treatment. Sometimes patients can also have changes on the lips, and sometimes lips only, some ulcerations, which can be painful in some patients. And that may certainly be related to graft versus host disease. A lot of times there are other potential reasons for these changes. For example, patients can have herpes infection or cold sores on the mouth. If patients have a history of cold sores, sometimes patients tend to believe that that's the same thing that happened a year ago, 2 years ago, and may not share that with the doctor. But as I said, any symptoms that happen, the key is no matter what the cause is or is going to be, best thing for you to do is to share with your healthcare team, your transplant team, and then they let them help you and let them guide you in terms of what to make of that symptom and how to help you control those symptoms, and then diagnose whether they are related to graft versus host disease or not. Now, these are some examples of chronic graft versus host disease involving your nails, hairs, and joint. Yes, nails, hairs, and are appendages of our skin, and similarly, like involvement of skin, nails and hairs can also be involved. Like patchy hair loss can certainly be because of graft versus host disease. Nail changes, scarring can all be part of graft versus host disease. Joint involvement, as I mentioned earlier, not able to extend your joints, your hands, your shoulders, tightness, pain, restriction of motion, etc., etc. Noticing some skin dimpling or thickening of your skin, all essentially can be changes of skin colors, discoloration, lack of skin pigmentation, can all be essentially part of chronic graft versus host disease. Now, can we prevent this graft versus host disease from happening? And the answer is yes. We certainly can prevent graft-versus-host disease from happening in at least some patients. So whenever we do a transplant in every single patient, we give them a cocktail of medications called graft-versus-host disease prophylaxis. And these medications are supposed to prevent and or reduce the risk of graft-versus-host disease from happening. And we have gone a long ways in the past 4 or 5 decades to improve these regimens to prevent graft-versus-host disease. Just to give you a brief idea what we used to do back in the days and where we are at now. So in 1970s, there was a single agent drug called methotrexate that we used to prevent graft-versus-host disease. This is very early on when transplant came about in humans to treat diseases with allogenic transplant. In 1980s, another drug came about called cyclosporine. And then in late 80s, there was a combination of both of these drugs that became standard of care to prevent graft-versus-host disease that thus made some improvement. And then later on, similar drug combination like cyclosporine and methotrexate, tacrolimus and methotrexate became standard of care. Now, since then, till very recently, although there were some changes that happened, but the incidence of graft-versus-host disease, despite these regimens, remain quite high. But more recently, in the past 5 to 10 years, a new regimen that has come about, which is a standard of care now, is called post-transplant cyclophosphamide-based graft-versus-host disease prophylaxis. And that essentially has really improved and reduced quite a bit the incidence of graft-versus-host disease. And this has been one of the major advances in prevention of graft-versus-host disease in the past 4 or 5 decades. There was a very large randomized phase 3 clinical trial. So in medicine, whenever a drug is approved, it's based on all the clinical trials and studies that we do in the background. And one of the highest level of evidence is a randomized phase 3 trial. And if it's positive, it shows us that the given study or the new regimen is better than the regimen that we have had before. So what this trial did was it compared the then standard of care, the 2-drug regimen, tacrolimus and methotrexate, with this new post-transplant cyclophosphamide-based regimen that comprises of 3 drugs. Post-transplant cyclophosphamide, what we call in short PTCy, tacrolimus, and MMF or mycophenolate. Matched related donors, meaning sibling donors were part of this trial. Also matched unrelated donors were part of this trial. It was a pretty decent sized large trial, and they all received reduced intensity chemotherapy. What did the trial show? It showed that the outcomes were superior or better with this PTCy regimen as compared to the prior standard of care regimen. We use a term called graft-versus-host disease-free, relapse-free survival. What that means is patients who receive stem cell transplant, they do not have graft-versus-host disease and they do not have relapse of their malignancy at any given point after transplant. And if you look at this, with the PTCy regimen, that outcome was 52.7%. That means 52.7% patients after transplant were graft-versus-host disease-free without cancer and were doing well, as opposed to about 34.99%, about 35% with tac methotrexate. So if you look at the difference, about a good 20%, 15 to 20% improvement in the outcomes. And that is pretty impressive in our transplant field. So since then, post-transplant cyclophosphamide has become a standard of care, at least in reduced intensity conditioning regimen. If you look at this, the severe graft-versus-host disease only happens in 6.3% patients in the acute form. Chronic graft-versus-host disease in the severe, moderate to severe form is also less than 10%, but this is all grades chronic graft-versus-host disease, which was better with post-transplant cyclophosphamide. So essentially, in the past 5 to 10 years or so, remarkable improvement and advancement has been made in the field of stem cell or donor transplant, and now we are able to essentially prevent bad graft versus host disease from happening in more patients than we ever able to do before. So now where we are at with graft versus host disease prevention, or the strategy we use. So as you can see that, we have made a lot of advancement and improvement in graft versus host disease with this newer regimen, but GVHD still happens. So although it's better, but still remains a problem, As you can see that, we have about 52 to 53% patients who do well without these issues after transplant, but there are other patients who still do develop graft versus host disease. And, in an ideal world, we would want this 52% to improve to 60%, 70%, 80%, or even 90%. And what that means is, although we have come along so far, but there's a whole lot of more advancement and improvement we need to do in graft versus host disease prevention science. Also, although this newer strategy or regimen is very good in preventing graft versus host disease and much better than what we have done ever before, but it's not a benign treatment. Post-transplant cyclophosphamide is actually a chemotherapy that works in this particular context to prevent graft versus host disease, but it causes some issues. There's a complication called cytokine release syndrome that happens in a fraction of patients. It increases the risk of infections that a lot of investigators and teams, including our group, has described in the literature. It may increase the risk of graft failure in some patients or rejection in some patients. It also puts patients at the risk of secondary malignancies years after transplant. So although it has improved and moved the needle quite a bit, but it's not the perfect drug. So in that context, there are new therapies that are being studied out there in order to improve, number one, further improve the outcomes of graft versus host disease, and also essentially other drugs that may have less issues or less toxicities. One of the agents out there, which is in clinical trials right now, is called abatacept. There was a phase 2 trial that compared the standard of care tacrolimus methotrexate with addition of abatacept, and it appeared promising. And the acute GVHD incidence was way down in these patients in this trial. And the bad acute GVHD, the severe acute GVHD in one of the group of patients in this trial was fairly low, 6.8%. Now there is a final trial, ABBA-3 is currently ongoing, and we are awaiting the results of the final trial to see and to tell us if it's going to further improve the graft versus host disease endpoint and is better in terms of a side effect profile and tolerance. Now changing gears to a little bit from prevention of graft versus host disease to what if somebody develops graft versus host disease? What do we do? So the answer to the question is yes, we can treat first of all, we try to prevent graft versus host disease, and we are trying to do a lot of science and trials to see if we can improve prevention of graft versus host disease. But if it happens, yes, we can treat graft versus host disease. And there are many treatments that we have today in 2025 which we did not have if we go back 5 to 10 years ago. So that's the good news. Yes, it's treatable. And then now we have several drugs. Some of them are FDA approved, which we did not have a few years ago. So when I started practicing as a transplant physician about 9 or 10 years ago, there was no drug approved for the treatment of graft versus host disease. But there has been so much research and investigation and science and trials that have come about in the past 10 years that has led to approval of many drugs to treat graft versus host disease. I'm showing you this table. I know this is a very busy table, but the idea to show you this table is just to kind of get this message through that if graft-versus-host disease happens in somebody, it's okay. We have tons of drugs, tons and tons of drugs that we can use, or strategies that we can use to treat both acute and chronic graft-versus-host disease. So this is a table that shows all kinds of strategies we have that we can use to treat acute graft-versus-host disease. These are some of the drugs that are approved to treat chronic graft-versus-host disease that we did not have, 5-10 years ago. Steroids has always been the first line of graft-versus-host disease, but now we have Jakafi, ibrutinib, Rezurock, axatilimab, at least 4 drugs that are FDA approved to treat refractory or resistant graft-versus-host disease that we did not have before. So in that context, these are exciting times in terms of management of graft-versus-host disease, and we have more arsenal in our back pocket which we did not have before. And all of these drugs are effective, more effective, and are reasonably well tolerated to treat graft-versus-host disease if they happen in our patients. This is another table showing other strategies that we have to treat chronic graft-versus-host disease. It includes other agents and other strategies besides what was present in the last slide for the treatment of chronic graft-versus-host disease. So a lot of development, a lot of good news, better regimens to prevent graft-versus-host disease to occur in the first place, better, more improved regimens to treat graft-versus-host disease if that happens. But despite these newer regimens and better prevention regimens, we still see graft-versus-host disease in some patients, and it still remains a problem. As I said, ideally we want GVHD to not affect any of our patients, and the outcomes, the long-term outcomes, I want them to be 80%, 90%, meaning that many patients should, or even more, 100%, should be well without GVHD complication years down the road. That's our goal in the field of transplant. But we still see patients with graft-versus-host disease. So what can we do? In terms of the healthcare team, the providers, the doctors, the nurses, and the patients and the caregivers, the key is monitor for the symptoms and report any symptoms or signs that you might notice in the patient who have received allogenic transplantation right away. But the transplant teams, wherever the teams are, the transplant group we are always easier to reach. That's the nature of our work. So if you are a patient or a caregiver of graft-versus-host disease and you notice any new symptoms or worsening of any symptoms, be it infections, rashes, nausea, diarrhea, appetite going down, taste alteration, you notice a spot on your lip, on your mouth, in your mucosa, changes in your urinary streams, changes in your joints, any tightness, any cramps, anything at all, do not wait. Just speak to your provider and your transplant team and make them aware that these are the symptoms you are experiencing so that they can guide you in how to manage those symptoms, and if any of those symptoms are related to graft-versus-host disease or infection. That's the key aspect of it. Because in a lot of situations, graft-versus-host disease, we are able to manage it easier if we can pick it up early. If the patient is having a symptoms and they do not let the transplant team know for weeks and months, the GVHD can progress, can become from mild, moderate to severe, and it becomes more challenging to treat and control. So that's one of the key aspects of treatment and management of graft-versus-host disease. Monitor and report your symptoms right away. Second major aspect of improving what we have today and making it much better to prevent and treat graft-versus-host disease is to put our patients and do more clinical trials. I tell my patients that the best thing I can do for you at any given time is to put you in a clinical trial. And the reason is, as I mentioned, although we have made tons and tons of improvement in the past decade in preventing and treating graft-versus-host disease, we are able to use much more effective and much more many drugs in this aspect, but still graft-versus-host disease remains a problem with the current standard of care. What that means is what we have is good, but it's not good enough. We need better drugs, better strategies to prevent and treat graft-versus-host disease. And we can only do that, we'll only be able to do that to come up with more newer science, more newer research, better effective and better tolerated treatment regimens. And the only way to make that happen is to move the science with clinical trials. And we cannot do that without our patients' help and our family members and caregivers' help in participating in these clinical trials. And it's possible that if any of these clinical trials have drugs that are going to be eventually be approved, that may give you some chance of getting a much better outcome.
Awesome. Thank you very much, Dr. Khimani. This was an excellent presentation. We're now going to begin the question and answer session. We have about 13 minutes left and lots of questions. But if you have a question for Dr. Khimani, please use the chat box on the left side of the screen to submit your question, and we're going to try to answer as many as possible. So our first question is from a person who is 8 years post-BMT, and since early last year, their oncologist has been calling the chronic fatigue resulting from the BMT they're experiencing chronic graft-versus-host disease, which manifests as chronic fatigue. They're curious if chronic fatigue is now being recognized as GVHD.
Well, that's a very good question. Chronic fatigue can essentially can be related to chronic graft-versus-host disease in some patients. So I'm glad you were able to share that information and the symptom with your team. So there are tons of different symptomatology of graft-versus-host disease that can happen in any given patient at any given time after transplant. What we need to do is we need to discuss those symptomatology with our transplant team. So I do not know if you have spoken to the transplant team or not. A lot of times our patients are getting transplantation, and if they're overall doing well and they're off immunosuppression, they may come from a variety of different distances and states, and they essentially move on and are taken care of by their local doctors. So if you're having any symptoms, best would be to discuss with your transplant team where you received your transplant, or any transplant a team that is closer to you. Any symptomatology, including chronic graft-versus-host disease, can be related to graft-versus-host disease like chronic fatigue, but there are tons of other differentials that can also cause chronic fatigue. So if the chronic graft-versus-host disease is an issue here, the transplant team should be able to do the workup and help you in terms of how to manage your symptoms and treat if it's graft-versus-host disease.
Good deal. Thank you. All right, our next question is, how long does GVHD prophylaxis have to be taken? For example, with Jakafi. Does Jakafi always have to go together with PCP prophylaxis? Is anemia a typical side effect?
So there are two-part questions. One is, how long the patients have to be on the drug that we use for graft-versus-host disease prophylaxis. So in general, we try to taper off all the immunosuppression or graft-versus-host disease drugs in the first 6 months to a year, essentially, if the patient do not develop any symptoms of graft-versus-host disease after transplantation. But if the patient were to develop any symptom of graft-versus-host disease, then some of those drugs or more drugs have to be continued for longer periods of time, could be several months or even years in some patients. If you were to develop graft-versus-host disease and your team puts you on further medications like steroids or Jakafi or any other drug, that drug has to be continued as long as it works and as long as you tolerate it. At some point, it could be 6 months from the initiation of the drug, a year, year and a half, 2 years, and even longer in some patients. If your graft-versus-host disease is controlled or goes into remission or near remission, at that time your transplant doctors attempt to taper the drugs off slowly and as safely as possible. And in some patients we are able to get you off all the drugs slowly and safely in time, but in a lot of patients, graft-versus-host disease symptoms may flare and you may need to go back on these drugs. Some patients may have to remain on these drugs for rest of their lives. So it depends on how your body reacts and responds to the treatments. Now, in terms of the side effects, anemia, yes, anemia and low blood counts is a very common side effect from Jakafi, and it has to be managed in conjunction with your local doctors and your transplant team. If it's manageable, you're not requiring too many transfusions or no transfusions, and it does not give you too many symptoms, then we try to continue the drug, the Jakafi, especially if it's working and if you're tolerating it otherwise well.
Good deal. All right, our next question is, are infection risks mostly from the intestinal mucosal membrane damage?
So risk of infection is high after transplant in any patients who go through allogeneic stem cell transplant for a variety of reasons. Yes, one of the reasons is the mucosal damage that happens early on with chemotherapy and radiation. But the chemotherapy and the radiation itself suppresses your immune system, and that puts you at the risk of infections. The damage to the mucosa can cause organisms or bacteria and stuff that a lot of times our body normally have, and they can invade and cause bacteremias and infections early on after transplant. And then the drugs that we use to prevent graft-versus-host disease, all the pills and the medications you're on, some of them are immunosuppressive medications. And all of these things do put you at a risk of infection. The transplant itself, the chemotherapy, the drugs that you are on, all of these suppresses your immune system and you remain at a risk of infection after transplant. But the farther out you are from transplant, the less medications you are on moving forward, the risk, it gets better. You're at 6 months after transplant is a higher risk of infections than 2 years after transplant, especially if you're off immunosuppression.
Good deal. And our next question is, how often does diarrhea and nausea need to occur in order for it to be considered acute GVHD? This person has liquid diarrhea several times per month, every month since transplant, and also has nausea several times per month. Would you consider this classic acute GVHD, or is it just normal for any person?
So any nausea and diarrhea that you have after stem cell transplantation can be and any other manifestation of that we associate with graft-versus-host disease can be because of a variety of different reasons. So for any symptoms you have, there are several differential diagnoses. It could be, for example, just to give you an example, our patients after transplant, due to some of the drugs we use, they lose magnesium. And a lot of the patients require oral magnesium drug. The oral pills of magnesium can also affect their gut and cause some diarrhea to some level. So that's one of the differentials of having diarrhea because of the oral magnesium drug. But that does not mean that all patients who are having diarrhea a month or 2 months after transplant is related to oral magnesium drug. In a fraction of patients, it can be because of infections. It can be because of graft-versus-host disease. So essentially, it's the transplant team who can do the workup and then decide what is causing a diarrhea or a nausea in any given patient and what's the best way to manage those symptoms. If you are having symptoms of nausea or diarrhea months down transplant, it may or may not be normal. If you're just having manageable, a couple of bowel movements lose a day because you're on oral magnesium, that may be related to the drug. But if you're having a lot of nausea, that's not normal. There's some aspect of your gut that is not happy because of graft-versus-host disease or inflammation or changes in your gut, what we call microbiota, so on and so forth. So best is to discuss with your transplant team, and they can help guide you and do some workup to figure out what's the cause of it. The workup may include checking your stool for infections, checking your stool for chronic diarrhea reasons, doing endoscopies, and taking a full history and looking at your drugs and so on and so forth.
Awesome. Thank you. And this may need to be our last question. We have about 5 minutes left. But this person has fairly severe oral and ocular GVHD and was also a head and neck cancer patient in 2014. They're wondering if there's anything that can help relieve the symptoms they're experiencing. They confer with their local transplant team and their treatment team, but would appreciate your input as to what to expect as it relates to both symptoms and therapies in the future.
So yes, it can be quite challenging to treat some of the symptomatology of graft-versus-host disease. As I said, there are many drugs that are now FDA approved to treat graft-versus-host disease. So I only mentioned the systemic therapies in my presentation because of the lack of time, the oral drugs or IV drugs to treat graft-versus-host disease. If you are not on any of those drugs, or you have not tried them in the past, or you tried them in the past, they worked, but you were being tapered off of those drugs, all of those drugs can essentially be tried to see if your symptoms improve. But in addition to systemic drugs, there are several topical therapies like mouth rinses, drops of different kinds, different other strategies like variety of different lenses, autologous serum tears, things like that, that essentially can be used or tried to help you with your symptomatology. Now, in terms of systemic therapy, especially immunosuppressive therapy, becomes a challenge in patients who have other malignancies or solid tumors. And the reason is any immunosuppression that we use, and a lot of our drugs that we use to treat graft-versus-host disease have immunosuppressive effects and hence can increase the risk of other malignancies and solid tumors. So we have to be very careful how much immunosuppression or systemic therapies we use in patients who are at risk of progression or of other solid tumors. But the transplant team can decide on the role type of systemic therapy. If you have symptoms, certainly they can pick up a drug to help you with your symptoms. Also, referral to and following up with specialized centers and specialists. For example, if you have severe eye graft-versus-host disease, there are eye doctors who focus on eye GVHD, and they have topical therapies and topical strategies. Some procedures they can do depending on the type of symptomatology in your in the eye. Special scleral lenses, special drops. Autologous serum has a role in terms of other things can essentially be done for the mouth graft-versus-host disease. In addition to steroid rinses, there are other immunosuppressive rinses. For example, one would be azathioprine rinses, and things like that can essentially be used as a topical therapy. But if your symptoms are severe, they may have to try one of these either FDA-approved drugs or other drugs or strategies like, for example, photopheresis in some patients, so on and so forth, that we use to treat graft-versus-host disease symptoms. But there are several lines of therapies, yes.
Well, thank you very much, Dr. Khimani. I'd like to thank you on behalf of BMT InfoNet and our partners and everyone in attendance today. And thank you to all those in attendance for your excellent questions. I'm sorry if we couldn't get to all of them. But please contact BMT InfoNet if we can help you in any way, and enjoy the rest of the symposium.